Welcome back to the show, Talk with Your Doc, and today we have Dr. Scott Cassie with us, and we are talking about bariatric surgeries, which are one of the treatments for obesity. Dr. Cassie, you were talking about different surgical options, and how do one select different options among those 4 options you mentioned? Which one should go for?
Yeah, again, this is a bit of a geographical issue. Everything is provincially mandated, at least in Canada, and so it makes things a bit more difficult. I think typically, as I said, the gastric band is something that's being done privately nowadays, and I think it's slowly being phased out, and to be honest, it's not something that we recommend to any of our patients at this point. The duodenal switch, as I mentioned, more for super obesity and BMIs of 60 and higher, and so that subset of the population is someone that I generally encourage to seek.
Super obesity means too much, maybe 400, 500 pounds?
Yeah, so BMI of 60 is probably, in most individuals, is looking at well over 400 pounds,
400 pounds.
Again, depending on height, yes.
Okay.
And so that takes care of that subset of the population. And then with regards to sleeve and bypass, it really comes down to a few features. We know from the long-term data that bypass gives good weight loss. Patients can keep most of that off. We also know it's a very good therapy for things like diabetes, high cholesterol, and high blood pressure. Probably a little bit more effective than the sleeve.
Okay.
So in most cases, if a patient can have a bypass, we usually push them towards a bypass.
Okay.
That being said, the sleeve is still a good operation. The weight loss is slightly less than what we see at the bypass, and not quite as effective for things like diabetes, high cholesterol. So there's certain times where if a patient's had previous surgery and they have a lot of scar tissue and we can't safely do a bypass, in some cases if they have some inflammatory bowel disease or some sort of malabsorptive disease, if they have liver cirrhosis, or if they're dependent on anti-inflammatory medications, those are some of the scenarios where we generally recommend a sleeve gastrectomy instead.
So which one has low morbidity or mortality associated? Which one of those 4 surgeries is less risky?
To be honest, what I tell most of our patients, at least in the perioperative phase, the complication rates are essentially the same between most of those. We'll leave the band out of it for now. But if you talk about problems such as bleeding, problems such as wound infections, those are pretty infrequent, happen about 1% of the time. When we talk about problems like blood clots or pulmonary embolus, those occur in about 1% of patients as well, and that's pretty much across the board.
Right.
The other concerns are leaks after surgery, which occur in about 1 to 2%. And if you look nowadays, the overall mortality of surgery, we used to quote about 1 in 200. Now it looks like it's probably closer to about 1 in 500 to 1 in 700. So it's still not without risk, but better than a few years ago for sure.
Right. So once somebody gets the surgery done for the obesity, how long it takes him to lose the weight and how much weight one can lose?
Yeah, so most of our patients are losing weight before the operation. So in order to do the operation safely, we put them on a weight loss shake.
Okay.
The main reason for that is it actually helps to shrink the liver volume by up to 40%.
Okay.
And we're trying to get up to the top of the stomach to safely do the operation. If the liver's too large, we simply can't do it. So they usually are losing at least 15 to 20 pounds preoperatively in most cases.
With the diet and exercise.
Exactly, just with the shakes we give them and exercise up front. After the operation, the initial weight loss is usually quite rapid. But what I tell them in most cases, again, it's hard to quote numbers because it depends on their starting weight, but I think on average, after a gastric bypass, for example, we usually see them lose about 100, 150 pounds the first year.
1 year.
What we typically look at is their excess body weight, so the amount that they weigh compared to what their ideal body weight is.
Yes.
And if you look at that, we usually tell them they're going to lose about 50 to 70% of that excess body weight in the first year. And that's a pretty typical amount they see with most patients.
And then over the period of next few years, are they able to sustain that weight loss, or they gain the weight back? How does that happen?
In general, they will lose weight for about 18 up to 24 months post-operatively. Usually they'll start to plateau at that phase. It definitely is a slow weight loss after that. A lot of patients will gain back a very small amount, a few percent. We do have some patients that will regain a large amount. And so I tell them what I was always taught during my training, that this is not a magic pill. This is essentially like pressing the reset button. So we'll take them back 20 years. We'll take off 100 to 150 pounds. Usually we'll get them off of some, if not all of their medications, and they get a fresh start. If they have poor behaviors, similar habits to what they had previously, they may regain the weight and maybe end up in the same boat they were in.
So does this surgery affects overall health of a person other than the weight loss, like other parameters of the health?
Sure, I think that's actually the biggest impact. So everyone talks about the numbers, but when you really look at it, the Swedish trials from about 10 years ago showed us that if you have an obese patient who undergoes an operation, regardless, they looked at a few different procedures, 10 to 15 years down the road, there is a significantly higher chance they would be alive if they had surgery than if they did not have surgery.
Oh.
So that was the biggest thing. And the reasons for that, as you've touched on, it's a good cure or improvement in diabetes. High blood pressure, high cholesterol all tend to improve.
They all
Sleep
go down.
apnea, exactly. So we see vast improvements in all those things. And for reasons that we don't understand, some of those improvements occur immediately. So if we have patients that come in on 1 or 2 oral medications for diabetes, within 48 hours when they go home from the hospital, they're usually off those medications completely, and they usually stay off them. Okay. So it's an immediate effect for some of those medications.
So diabetes maybe get cured also probably?
Yeah, there's pretty good data that if we do a bypass and we follow these patients for a year afterwards, the chance that the diabetes will either be cured or significantly improved is about 80 to 90%.
90%. And same with the heart disease and blood pressure.
Yeah, exactly. Those numbers aren't quite as favorable, but again, in terms of hypertension, we see about a 70-75% cure rate after a year. So the response is quite rapid, and it's quite profound.
So now, once one undergoes surgery, what is the change in the diet or the nutrition?
Yeah, it's not as drastic as most people assume. When the patient goes home from the hospital, they are on a fluid diet for a couple of weeks, and they upstate from there, they go to pureed diet.
So after surgery, they go on the liquid diet? Then.
Exactly. So it's thick fluids essentially for the first little while everything heals. Within about a month, we see them in the office, and they're starting on some solid foods at that point.
Okay.
The general recommendations are that they eat multiple times per day, and they eat small amounts. And if you look at what they're eating at that point, it's generally a fairly overall normal, healthy diet. We encourage them to get protein at every meal, usually some solid protein, so they get that full sensation quite early. And there's usually a vegetable involved with that. But if you look at it, it's actually a fairly normal, healthy diet.
That's after third month, that probably.
Yeah, usually they're starting that food about a month after, and within a couple months they have a pretty set diet.
So that's like a small child feeding, starting, first liquid, then semi-solid, and then
essentially
solid.
Similar to that, that's right.
And then they come back to the normal, but the proportion has to be maintained probably.
Exactly. So they work very hard with our dietitians, and they get about a 5-year follow-up in the clinic there to make sure that they maintain these changes long term.
Right.
So essentially they're encouraged to eat at least 5 times, sometimes 6 times a day, very small meals, always with protein. We try to separate their liquids and solids because there can be issues with what we call dumping syndrome on occasion. But overall, if you look at what they're eating, it's actually a fairly normal diet.
Thank you, Dr. Cassie. We'll take a short break and we'll come back.
Thank you.
Thank you. Please stay back for the last part.